Welcome to our online course, What We Say Matters, using our words to lift people up. My name is Beverly Tomasian, and I love presenting this conference once a year. We update it yearly because it's so important. I want to make sure everyone who wants to access this information can access it either live or record it. We're going to post this recording and it's free to view, and the handouts are also available for free because we feel that this content is so valuable for our clinical practice and to make meaningful connections with people living with diabetes. So happy you're here. Here's our website. Just want to orient you to our website. You could click on this free resources tab, and there's a drop down with lots of great information, cheat sheets, pocket cards, webinars, and our free CDCES coach app. It's like having a coach in your pocket. On there, we have our pocket cards, we have our cheat sheets, we have question of the week. I mean, I really try and infuse our website and our free content with things that are helpful in your clinical practice. I work at Indian Health Services 1 day a week, and I utilize all these materials because diabetes is complicated and there's a lot of information to know. So we want to be a resource where you can go and just get that information easily. We're so lucky to have Brianna. She's our Director of Operations and Customer Happiness. If you have a question about certification, where to find something, are we going to have a sale? She's the person you can call, email, chat. She's really an amazing, kind, generous human. I'm so lucky to have her on our team. So hopefully you get to meet her too. Before we start, I'd like to do a land acknowledgement, and we do acknowledge that and are mindful Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda, and we recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. For this webinar, we're going to talk about language, and language is really important. It's not just the words we use, it's the meaning and the feeling and the gestures that accompany those words. And so nobody expects us to get this perfect. Believe me, I've been working on this for years, and sometimes I'll still say things and I'm like, oh, I wish I could have pulled that back in. So it's not about perfect, but it is about intention. Like, what is our intention? What are we trying to convey? What is the feeling behind our language? And I think more than the words, as you know, people pick up on the feeling that we emote. And I think we keep that in mind as we move through this process and this relearning of some things, because certainly I learned in a very traditional way how to speak to people, about people, and I've really revolutionized my language. And the great news is, by me changing the way I talk about diabetes and people living with diabetes, it connects with my providers. So they hear me talking in that way, and then they start talking in that way. It's really beautiful how one person changing their use of language and their intention around language can really influence a practice setting. So always have hope is what I want to say to all of you. And that's why I have this balloon there, right? We want to lift people up. We want to believe in the opportunity to make a difference in the way we approach people living with diabetes, because as you all know, diabetes is riddled with shame and blame. And when people have those feelings of shame and blame, they often don't show up for appointments, and they may not be as comfortable being honest if they are feeling judged. So in the next half hour, we're going to kind of drill down into that a little bit more and just provide some strategies to connect with people in a meaningful way, making them feel welcome, included, and not judged, which is critical. So what are we talking about? Words and approaches that can be left behind. Let's leave the old baggage behind. Describe diabetes language that is respectful, inclusive, person-centered, and imparts hope. And practice communicating about diabetes using phrases free from judgment. We're going to take a strength-based approach. And this all started, really, Jane Dickinson kicked it off with this article, The Use of Language in Diabetes Care and Education. That's her vision, her research. She understood how our language use was impacting people living with diabetes. And so her sharing her knowledge translated into the Association of Diabetes Care and Education Specialists, ADCES, creating this quick guide for healthcare professionals. And in the ADA standards now, it talks about using person-centered language. And I just want to read you a few quotes here from the Language of Diabetes handout, which you can access on our resource page. How we talk to and about people with diabetes plays an important role in engagement, conceptualization of diabetes and its management, treatment outcomes, psychosocial well-being. For people with diabetes, language has an impact on motivation, behaviors, and outcomes. So we recognize that diabetes is complex and challenging. We recognize that every member of the healthcare team can serve people with diabetes more effectively through a respectful, inclusive, and person-centered approach. And I love this to say, we serve people with diabetes. It's a whole different thing than saying, oh, those are my patients. And so we're moving away from using that word patients and saying the people, the individuals, the people with diabetes that we serve. And that really, that shift of language is more inclusive and collaborative. Okay, let's keep talking. Stigma that has historically been attached to diagnosis of diabetes can contribute to stress and feelings of shame and judgment. So lots of time people with diabetes may feel like they're not doing their diabetes right or perfect, and they feel like they're failures, and they're so afraid to show up for that appointment because they feel like they're going to disappoint us. So we want to let them know, no matter what, just you showing up is enough. Just you showing up is enough. And then, we want to recognize all the things they are doing instead of taking an inventory of where they're not meeting the standard. So we've really moved a long way. Like when I started in diabetes education 30 years ago, it was about checklists and, we would say people are cheating and eating these bad foods. We don't talk that way anymore because a person makes a choice. They don't cheat. It's not cheating. If I eat Jello, and I have diabetes, am I cheating? No, I made a choice to eat Jello, just like I would make a choice to eat apples. So we change the way we look at it, and we could say to the person, hey, there's no bad or good here. There's no cheating. You're just making a choice. And at that time, you needed Jello. And then you might want to say, is that something you would like to work on? And that person might say, yeah, I'm eating so much Jello. Okay. What would that look like for you? So you notice I'm just not even saying, yes, let's cut out the Jello, because I do want to cheerlead, guys. I want to tell you something. I'm very enthusiastic, right? And I could see like, oh yeah, they did this, this, and this. They're totally going to improve their health, but it can't come from me. I wish it could, but it has to come from them. So our goal is to find the expert in the person, to find out what changes they're working on and how they might succeed. So it's so hard because we're used to providing instruction. We're moving away from just giving information because, gosh, we've got a lot of information, right? You all listening here today are super smart humans. Probably many of you are overachievers. And so you can recite a lot of things about diabetes, and you're excited to share that. But the thing is, the more we're quiet and listening, coaching, acknowledging, the more we're offering that individual, because ultimately diabetes is a self-managed condition. So if you notice yourself talking a lot, it might be a sign that, maybe I need to listen more. Just kind of check it out, do a very kind self-evaluation and see where you're at with that process. And I was thinking about this a lot. A lot of the clients that I serve are Spanish speaking. Yeah, my Spanish is pretty good. It's getting better, but it really makes me be in the moment because I have to listen so intently to every word. I can't formulate something I want to say. I'm just like holding on to every word to make sure I have a significant understanding of it. And even if we speak the same language, we still want to do that. Listen and hear what they're saying, not just the words, the body language, the in between the words, to really help them move in the direction they're ready to move. Okay, so here's some stigma associated with diabetes. We used to call people diabetics. It's a person with diabetes. It's not, I always tell people, it's not your fault you have diabetes. Here's a pancreas, right? And this is what your pancreas looks like when you're born. It has its complete array of beta cells. Well, with diabetes, because of genetics, as we get older, we get heavier, maybe we move less, we lose a lot of our beta cells. So this is what type 2 diabetes looks like. You have about 20, 30% left of your beta cells. That's not your fault. If you don't have the genes for diabetes, you don't get diabetes. You have to have the genes plus the environment, right? So there's a lot of people who are have extra weight, who don't exercise, who eat junk food, who never get diabetes. So I work a lot on saying it's not your fault. It's your pancreas's fault. It's your genetics. So people with diabetes do a lot of beating up of themselves. They may not tell you about it, but they have a lot of critical inner voice happening many times, or maybe there's critical other voice. So we want to let them know we're on their side. We believe in them. They can do this. It's not their fault. The other thing I ask a lot about is early adversity. So I was working with a client and really struggling with their body weight, wanting to lose weight, having a lot of anxiety. And I just asked this simple question. I go, "Oh, how was your childhood?" And they go, "Well, it wasn't, too bad. My dad died when I was a teenager, and then I had to help first funeral arrangements, and then I had to leave school and go to work early, and I was working a lot and trying to take care of my family and my siblings. And then we moved to America, and I was separated from my siblings. It was just this whole story of trauma." And the person who was telling me this story didn't even recognize it. So many times people don't know they've experienced trauma or don't have the language to express that they've experienced trauma. So I often say, "Hey, how was your childhood?" And I just see their face and what stories coming out, because we know early childhood adversity has long-lasting impacts. And we know that people who've survived childhood trauma struggle more with lifestyle behavior, and also they're more likely to have diabetes, heart disease, and other conditions like cancer, that you can see right here. So can we fix this? Can we fix their early childhood experience? No, but we can witness it, we can acknowledge it, we can hear it, we can put words around it. And if it's appropriate, we can refer to mental health counseling. But many times just acknowledging it is very healing. It's very healing. Just me asking the person that question and me saying, "Wow, that sounds like a really rough childhood." That person had a sense of relief inside of them. I could just see their whole body language change. So it's really up to you how comfortable you feel with this. And there's trainings now on providing trauma-informed care that I've participated in that have been so helpful for me. So that might be an area you'd like to explore, because a lot of times it's not about lack of knowledge that stops people from moving forward on diabetes. It's that all that emotional firestorm around that really is a barrier. And then, what about us? Each one of us grew up in a different way, right? We had different types of parents, different types of cultural upbringings, different type of environments we grew up in. We carry that with us. We carry that into the room when we're talking with an individual. So we just want to be clear on our approach. Like I told you, I know I'm over enthusiastic, very cheerleady, and I'm goal oriented. I'm a taskmaster. I mean, those are all great things for being running my company, but I have to really tone it down when I work with people with diabetes, because I will scare people. I just have to be calm, hear them. And so I've tried to do inventory on myself and just listen. The other thing that is really big is weight. There's so much weight stigma in America, and there's weight stigma around diabetes, a lot of weight stigma. And there's a lot of blame. Well, if that person would just lose weight, or they need to lose weight, or they have diabetes because they have extra weight. There's so much around that. We're really trying to move toward getting rid of that stigma and just saying, "Hey, regardless of your body size, let's try and get the healthiest we can in your current body size." What you weigh on the scale is not a measurement of your success as a human, as a person with diabetes. It's just information. So let's move away from just thinking about what the scale says and saying, how do you feel? How's your energy? You know, are you able? I just had a gal who said, I want to lose weight. I'm going, well, you know, can you tell me more about that? She goes, I can't bend over to tie my shoes. So she clearly wanted it for functionality to lose weight. And so we explore weight in new ways now. And, you know, we really are ditching the term a person with diabetes and obesity or an overweight individual. We don't use that language anymore. I usually just indicate BMI, and I don't put any judgment around weight in my charting. Like a person with a BMI of 25 or greater, a person with elevated weight, something like that. Because we know that really our therapy doesn't change that much based on their actual weight. Our therapy approach changes based on what's most important for that person. If a person says to me, I really feel like I'm heavier than I want to be, okay, we'll move into supporting them with that, with their goals. But I love this information from Marguerite Fletcher. She has a weight neutral approach, and she's really an innovator and a trailblazer around the weight stigma and taking a weight neutral approach. She talks about encouraging engagement and promoting health behaviors as opposed to looking at the actual body weight, encourage body trust and acceptance, and advocates for using this language that uplifts people. And then instead of saying, I want to lose weight, I will continue to care for my body by doing X, Y, and Z. I will focus on small changes such as testing my blood glucose instead of checking my body weight every day. I will increase my self-worth by telling myself, I am worth it. I am enough. And I actually talk a lot to people with diabetes about self-compassion. And I'll say, just try and listen to what language you're saying to yourself. How are you coaching yourself? And, you know, and then I'm going to say, you might want to really try being more gentle in your approach and recognize what you are doing correctly. Or you might want to say to yourself something like, gosh, doing this diabetes stuff is really hard and I'm trying my best. That's a totally honest statement. Self-compassion goes a long way in helping people take more care, to engage in self-care than negative self-talk. So that's why, again, our language is so important, because when we use strength-based language, the person with diabetes hears that and they integrate that into their personal dialogue. I can't tell you how powerful it is. Okay, so please visit this site, ACEs Aware, that has free training on early childhood trauma and strategies to recognize it and coach around it. Okay, quick question one. JS is 17 years old and rarely shows up for appointments. A1C is 11.9. What might you ask JS? A, are you fighting with your parents? B, I'm curious about what is standing in the way of making your appointments. C, do you realize you are at risk for DKA? D, is there a reason you haven't been coming to your appointments? Okay, let's see. What might you ask JS? How would you ask it? We'll take about 20 seconds and just choose the answer you think is the best answer. And if you don't choose the correct answer, it's totally okay, because this is how we learn. We learn by choosing the best answer, and we learn by choosing the wrong answer. Both ways we learn. Okay, I'm going to go ahead and close the poll and share the results. 82% of you said, I'm curious about what is standing in the way of making your appointments. This is the best answer, and I'm going to tell you why. Because the word curiosity is very neutral and not judgmental. When we say, oh, I'm curious, you know, what's been happening? You haven't been making your appointments lately. I'm curious. I'm worried about you. Is everything okay? It's much more it provides much more opening than saying, hey, is there a reason you're not coming to your appointments? That last one, even though it looks good on paper, it can come off really judgy. So we want to figure out ways we can ask questions without evoking feelings of judgment by that individual. And the truth is, when people have experienced trauma, they may not show up for their appointments. They might not take their meds as prescribed. They may have trouble taking on new behaviors. So maybe it's not about, our effectiveness at all. Maybe it's about that person's life experience and their trauma and their emotional distress that we may not even know about, that's stopping them from being able to show up. And so the people who don't show up are the people, of course, we worry about the most. And we want to figure out a way to reach out to them, call them, check in. Lots of times if people don't come to the appointment, I'll call and say, hey, I really miss seeing you today. I hope everything's okay. We'll have, our secretary call and make another appointment with you. Just wanted to let you know I'm thinking about you, because we want to keep that connection open. Gosh, I would say that's the most important thing. Is keeping connection open and letting them know, even if they don't show up, you're still here for them. We can ask questions about trauma, like, in addition to the stresses of daily life, sometimes people with diabetes might have experienced something particularly difficult or traumatic. We also know experiencing violence is very common in many people's lives. I'm wondering if anything like this you might want to talk about. The other thing I do ask a lot is about safety. Do you feel safe at home? Because we know in many situations, the home environment can be hostile. It can be verbally hostile or physically hostile, and that can really impair people's ability to move forward with their self-care and show up for appointments. And of course, we can do these screenings before they show up to the appointment, or we can do them in person. We just have to figure out time, because it does take time to do these. And then we can ask about trauma. And I just put some examples of language here that you could use in asking about trauma. And I got that from the trauma training. Now, I want to ask y'all another question, so get ready to type. A person shows up to an appointment, forgets their logbook and meter, and tells you they are only taking their daily insulin injection about 4 times a week. What kind of feelings would that evoke for you? So if you could just type a feeling that if a person says, gosh, I'm here, but I forgot my logbook and my meter is at home. Oh my gosh. And you know what? I'm only taking my insulin 4 times a week. Could you just type in what kind of feeling that would evoke for you? And I won't read your name. So if you type it, I'll just say what the word is. So it's confidential. Some people might feel like, oh, they don't care. They're not compliant. Oh, they're not taking care of their diabetes. Or you might just feel exasperated, like, oh, again, they're not bringing it up. They're not following through yet again. Right. So somebody put concern, doesn't care, exasperation, they're struggling. Yeah. Not a priority or don't understand complications. Thank you. Non-compliant. Kim's curiosity, doesn't care, exasperation. Yeah, okay, thank you so much. So it can evoke a lot in us, because sometimes when people, like, suppose we made a goal with that person and we said, okay, here's the goal, you're going to check this and do this and come back, and they don't achieve those goals, sometimes we might feel like we failed, right? But I want to kind of take it out of the failure and not failing categories. And I just want to say, we might make goals with people to take certain actions and they're not realistic. And we didn't know that, they didn't know that, but we thought it was a reasonable goal and they couldn't achieve it. So what I would like this to evoke, this situation, is curiosity, right? To say, oh, can you tell me more about this? I know last time we talked, we had this plan, and it seems like, for whatever reason you weren't able to achieve that. I totally understand, but can you share with me what happened? And this person might say to you, you know what? I got to get the kids ready for school, and I'm supposed to take my insulin in the morning, and it's crazy in the morning. It's just like this chaos, and I can't remember to take my insulin. And you're like, oh, that totally makes sense. Maybe we could do it in the evening. And so when we take this curiosity approach and ask more questions, we can collaboratively get to a better approach that works for everyone. So we want to come from a place of acceptance. We want to let the person know, hey, I'm on your side. We want to focus on the person rather than the diagnosis. We want to hear about their life. We want to know what will work realistically. And then if we have a goal and it doesn't work, we want to just step back and do some more problem solving. We want to focus on what they are doing right. So we want to use language that imparts hope, that's based on fact. Actions are biology. Like, diabetes is not your fault. It's your pancreas. It's not doing its job. We want to be respectful, let them know that we're ready to foster collaboration and avoid shame and blame. We want to emphasize what that person is doing. Hey, you're taking your insulin 4 days a week. That's pretty good. How could we crank that up to 7 days a week? Or how could we increase it? So by saying you're succeeding 4 days out of 7 and acknowledging that person's like, hey, I am. That's a strength-based approach. Or you're checking your blood sugars and writing it down. You just forgot your logbook, right? So you go, maybe next time just take a picture of your blood sugars and send them. Or, we could talk about getting a CGM. There's different things that we could approach it with. So this is a collaborative problem solving, and we're allowing for a sense of dignity, a sense of agency, that person knows that they're part of the solution, that we empower them to be a part of this solution. So the language of diabetes education, you can see, has really shifted. We don't say, oh, we got to control your diabetes. I used to say that all the time. 4 strategies to control diabetes, but we know you can manage it. Controlling it's different because you can't fix the pancreas. So it's never going to be perfect. And that's the other thing I say, 80% of the time on target, the other 20%, we have wiggle room. Instead of testing your blood sugar, that's pass or fail, we check it. Really avoiding the word patient, individual with diabetes, person, participant, anything besides patient. Really only a patient if they're in the hospital. And we don't use that word normal. Like a person said to me the other day, what would my blood sugar be if I was normal? I go, oh, you actually are normal. It's just your pancreas isn't working. And then we've dumped this word compliant, non-compliant, because see, if you say they're non-compliant, it means I gave them orders and they didn't follow my orders. And that's not it at all. It's collaborative. So when you're collaborative, you can't be non-compliant. Let's do another one. A 78-year-old tells you they stopped taking their blood pressure medication. They say, it doesn't seem to matter whether or not I take them. What's the best response? A, acknowledge their honesty and ask them to discuss with their provider. B, gently remind them that stopping their meds is dangerous. C, ask them if they are experiencing trauma at home. D, explore possible reasons for this action. Let me launch this poll. All right, I see your votes coming in, so thank you. Okay, I'm going to close the poll. Thank you for having the courage to make a choice. So 76% of you said D, 18% of you said A. D is the best answer. And I actually run into this a lot because when I meet with individuals at our clinic, I'll say, oh, are you taking, I go through their med list ahead of time and I'm like, are you taking this med, this med, this? And I just had a person come in and says to me, I don't take my blood pressure medication. I'm like, oh, how come? He goes, I don't believe in it. How do you know if it's working? And I go, I can totally understand that. And so we had this big discussion about how, taking blood pressure medication every day helps keep the blood pressure less than 130/80, where he was thinking you would just take it if it's elevated. So when you actually explore reasons for actions, people have pretty good ideas. And then we can help get rid of mythology, because a lot of it is just based on false information or things that they need a little coaching on, or maybe it is too much medication and they felt like they were getting dizzy. So we could, like some of you said, acknowledge their honesty. Yes, we always say, thank you for being so honest. But we can have a discussion with them about it. Absolutely. We don't have to wait for the provider. Part of our job is to kind of explore, are they taking their medication, eating healthfully, moving their body? And if not, let's figure out why. And can we make some changes? So we are stopping shooting on people. SHOULD. We're not shitting on people anymore. Instead of saying you should exercise or you should eat healthy or you should, take your medications. Have you tried? We're going to ask a question. What's your favorite activity? When's the last time you did that? Do you think you could do that again? How many days a week? I mean, the truth is we make very few statements or action requests. We want to ask and elicit from people what would be reasonable for them to do. And you can see here, instead of shoulding, we're going to say, may I make a suggestion, asking permission to give advice. And, like if a person comes in and says, I don't want to get weighed, that's not refusing. We used to say, refuses to be weighed. They're making a choice. They're saying, I don't feel comfortable getting weighed. And when I weigh, there's a lot of emotional baggage around that. I'd like to skip it. Great. We honor people. It's a whole different way of looking at it, which I think is so much healthier. Let's do one more poll question. Which phrase represents the principles for communicating with and about people living with diabetes? You are checking your blood sugars daily. Your BMI indicates you're obese. Your fasting blood sugar is above normal. You should try and exercise 150 minutes a week. Let's see what y'all think about this one. All right, we'll take a few more seconds. Okay, I'm going to close the poll and share your results. So 80% of you said A, you are checking your blood sugars daily. The next most popular answer, your fasting blood sugar is above normal. And then D, some of you chose D. So A is the best answer. Why? It's non-judgmental, it's strength-based, it's recognizing what they are doing. You're checking your blood sugars daily. That is just stating the fact of what they're doing, which is really what we want to do. I try not to go overboard and go like, oh, you're so amazing. You're checking your blood sugars daily. You're like the best patient ever. Because if we do that, and then next week they have a hard week and they can't do that, they might feel like failures. So it's really tricky. You're trying not to be overexcited and, be judgy on the other end. But just to state what they are doing and say, that's a lot of work. I really want to recognize that. I use that word a lot. That's a lot of work. You really seem like you want to make this happen for yourself. The reason C is not the best answer is because it has the word normal in it. So we might want to say, oh, your fasting blood sugar is elevated. That would be a different way of saying it. Or, I would say something like people without diabetes or fasting blood sugar is 99 or less, and your blood sugar is 112. So I would just do a comparison between people without diabetes and people with diabetes. And then the D is not the best answer because it has that should word in it. We might want to say, hey, what kind of activity do you enjoy? Do you think you could try that? How many minutes a day? We're going to just ask questions to get them to narrow it down to the activity, how many minutes, and how frequently. And we're going to write it down. And guys, on my cheat sheet page, I have a whole free cheat sheet page. I have a goal plan that you can collaborate with people with diabetes and write down the goals you've established during your visit, and they get a copy. So then they have that, they could put that on their refrigerator and know and have in mind, oh yeah, this is what we're working on. So our coaching style matters. You can watch Little League coaches and see which ones the kids move toward. Do they move toward the coach who's critical and yelling and telling them that, how bad they are? Or do they move toward the coach that uplifts them, points out their successes, recognizes their struggles, helps them fill in knowledge gaps? We know from science that encouraging collaborative approaches tend to improve outcomes. We put together this person-centered coaching cheat sheet, and it's in our cheat sheets page. It provides a dozen simple coaching strategies for providers to help people believe in their ability to self-manage their diabetes successfully. So this is a great sheet to share with your colleagues, to read for yourself, to kind of walk through steps to provide person-centered coaching using using strength-based language. The thing is, our expectations of others can oftentimes like shadow our belief in what they can do. So if we walk into a room with very low expectations of people being able to do something, they're going to pick up on that, and they may not be able to rise to the occasion. So we want to really recognize that each individual has a capacity to learn new things, to take on diabetes management within their abilities, of course, but our belief in others leads to their belief in themselves. The other word that we hear a lot is empowerment. And I just love this slide and the language around it. Helping people discover and develop their inherent capacity to be responsible for their own lives and gain mastery. That's empowering somebody. The choices made by the person, not the healthcare provider, have the greatest impact. The consequences of self-management decisions affect the person with diabetes most. It is their right and their responsibility to be the primary decision makers. So as we move forward, I just want to say, if we think about burnout, when we move more toward an empowerment model, when we realize that person is making choices, that it's not our responsibility for their choices, we're less likely to get burned out and feel defeated. So when we have this new relationship with the individual where they might have made choices to eat certain foods or not take their meds, or whatever they decided to do, oh, I'm interested. Why did you choose that? And then we don't have to own it, and we don't have to feel like we failed. It's nothing to do about failure. It's just that person, for whatever reason, made that choice, and maybe they want to move in a new direction and make different choices. We can support them on that journey. Optimism and resilience. These beautiful flowers somehow make it through the harsh winter, and then the sun, shine comes out, and they say, oh, it's my opportunity. I can break through this hard earth, through this snow, through all these different stressors in my life, and I can still shine. I can shine my light here. Our connection with people with diabetes is healing. So our words have the power to create and transform. So on that note, I just wanted to share with you that we are celebrating 25 years. My company was started in 1998, in June 1998. And so July, we're celebrating 25 years of having this opportunity to serve you and to share this information. So we have $100 off sale on our top programs that I've listed here. It ends July 31st. And we're actually going to be live and in person in San Diego in October. We haven't been able to do our live shows for 3 years. I can't wait to connect with all of you, to see people, to reunite, and there is going to be swag involved. So on that note, I want to thank you so much for joining this very brief webinar on using language to lift people up. The resource page has a lot of good information you can download, print, share, and as I've mentioned, this will be recorded. So I invite anyone who would like to listen to this, to join us and take advantage of this information. I'll hang out after class to answer questions, but for now, I'm going to turn off the recording and say thank you so much for the care you provide for people living with diabetes. This is Beverly Tomasian signing off.